The fourth step is to map the current or as-is workflows and processes. Whatever tool is used, there is some science associated with mapping current processes. Each of these steps will be introduced here, and then we will look at some examples also using different types of tools so you can see how each works. The first step in mapping current processes and workflows is to identify what processes to map. It can be helpful for one person, perhaps in this case a consultant or the organization's project manager, to facilitate identifying all processes. This is important because despite our siloed environment, no one process stands alone. There are always boundaries or handoffs. Consider the nurse doing an admission assessment in a hospital. This process is dependent upon the admission process having taken place, or, as is currently the case, the admission process may be occurring almost or completely simultaneously. Having accurate patient demographics information is essential for both the admission and nurse assessment processes. Who performs these? Who relies on the other? This is actually a good example of a process currently in flux and needing help. So boundaries are often where the most issues reside. The second step in mapping current workflows and processes is to include all process elements in the as-is map. This would seem obvious, but as we are so accustomed to performing our work, we often can't recount all the actual steps. But it may well be that, for example, if a nursing assessment takes 2 hours, some part of that 2 hours cannot be accounted for on a first pass in a workflow and process mapping exercise. Even on a subsequent pass, it may be difficult to account for all of this time. And of course, some of the time will include interruptions of various types, all of which should also be documented. Again, while not all workflows and processes entail data and information or are intended for making improvements with an impending or existing information system, it is essential to first identify all inputs and outputs. These are the sources and uses of information or the tasks that trigger the next step to be performed. Second, to identify all tasks, including and especially tasks performed mentally. Third, to include all participants, including clinicians, staff, patients, family, caregivers, and service personnel, as applicable by credentials and location. And fourth, all decision points within a given process must be identified. In addition to boundaries being problematic, decision points are also problematic, largely because they are performed mentally. But mentally performed tasks without appropriate documentation, handoffs, or other forms of action produce issues. Decisions include alternative ways to perform a task for any reason at all, including who is performing the task. Maybe there's a substitute, maybe there are multiple people, maybe there are different nursing units for different specialties of care, etc. The nature of the patient's condition, etc. The third task then is to sketch the first pass at the as-is map. Once that process is known and as many of the process elements as possible have been identified, sketching the first pass at the current as-is map is a very important step. This we call mapping. It requires arrangement of the tasks in the sequence in which they are typically performed, and including alternative paths with explanation for how these alternatives arise. These, again, are the decision points that are often left out or not well described, and which are also a common cause of workflow issues. Now, at this point, as you're sketching this out, two things are likely to happen. One is what I call aha moments, recognition that, wow, that is what is causing the delay or the most frequent errors or whatever. This is a good thing to have happen. Participants recognizing this are then preparing themselves for change. The second thing that is likely to happen is not so good. And this is to start mapping what should be done. We obviously want to get to this point, but we need to make sure the as-is map is as accurate and complete as possible. We also want to make sure we have documentation of all of what the issues are so we can account for improvements that are necessary. Getting too far ahead of yourself by anticipating what change might help this issue will cause subsequent issues to be lost. Finally, the last step before turning to improvement opportunities is to brainstorm to ensure all tasks are identified and to create a final as-is or current map. Here is where input from as many as possible of staff and other stakeholders is needed. Even just time to remember a misstep is helpful. Certainly finding variations is critical and best performed at this stage. So how do we document our workflows and processes? We need to look at basic workflow and process charting, and we're going to do this through what I would consider a mini tutorial. We're going to first look at the basic systems flow chart symbols, which can be applied to almost any form of tool selected. There are just 3 symbols that need to be used. Ovals designate the starting and ending points that define the boundaries of the process being mapped. These anchors, if you will, help connect one workflow and process to another to ensure that gaps and handoffs are fully identified. A starting point may be, for example, nursing admission assessment for the nursing admission assessment process, or it may be a physician order. The ending point for the nursing admission assessment, which is largely an interview and physical examination, may be nursing diagnosis, in which case there would be another map that starts with nursing diagnosis to describe the process this takes, which is likely to be a more mental process culminating in statements of nursing diagnoses, perhaps coded using a nursing terminology for semantic interoperability, and ending with a plan of action. Note, however, that if the nursing admission assessment is carried out simultaneously with patient registration as an inpatient, patient admission may be a more suitable boundary distinction where there are potential alternative paths for different tasks performed by different people. The physician order process might end with the distribution of orders to the various departments tasked to carry them out, including lab, radiology, pharmacy, nursing, and others. So the ovals are very important in defining the starting and ending points of any given workflow and process chart. Rectangles explain the action steps in the process. Each action step should include 3 elements: who, does, and what. Example, RN takes admission assessment, or RN does admission assessment. A poor example of the same thing is Mary admits Mr. Smith. We don't know who Mary is. Is Mary an RN? Is Mary a patient registration person? And who is Mr. Smith? Is he a patient? Is he a family member? Credentials and an identification of what is being done are very important in healthcare because they define the scope of work someone is permitted to do. An RN, for example, cannot issue a medication order, although an RN can document a verbal order. Diamond shapes designate decision points. At a minimum, a diamond must have two branches, such as yes, positive, and no, or negative. There can be multiple branches, such as equal to, less than, and greater than, or to lab, to radiology, to pharmacy, to surgery scheduling, to respiratory therapy, etc. It is very important to remember that many decisions that impact a process and its flow are performed mentally, but must be documented. These are points where automation, new policies and or procedures, or even alternative staff performing a function can be considered. If there are many aspects to a decision, the mapper has two choices. First, separate each aspect into a separate decision point. For example, first decision is this with two branches. Next, one branch yields another decision with three branches, and the other branch yields only an action, no other decision. Returning to the decision with three branches, each branch may have yet another series of decisions. Now this sounds complex, and it is kind of complex. And if it is too complex, a decision table can be created as a separate document that is referenced in a single decision symbol. See Decision Table 1, for example. Although tools are available to use different types of symbols to mean different types of processes, such as manual versus automated data entry, paper versus computer display, entry versus storage, interview versus exam, etc., etc. Any process, both before a change is made and after a change is made, can be effectively mapped with only these three symbols: ovals, rectangles, and diamonds. I actually prefer the simplicity of using only these three symbols because I find that trying to select the right symbol for an action distracts me from thinking about all of the processes and their flow, which is really the crux of why we're doing this to begin with. Here we present a mini exercise or example of a workflow and process map that was drawn as a first pass, and I want to emphasize this is a first pass using the Systems Flowchart tool. I want to use this example as a first pass to show you both how well something can be done on a first-time basis, but also to identify that there are lots of things that we need to cover in addition to what is here. This particular example is a prescription renewal process in a clinic. And there are three flows essentially. There's one flow that starts with patient calls re-prescription, calls the clinic presumably. And that's a very short flow. The second flow is the main flow. It's where the pharmacy calls or faxes, presumably with the request for renewal, to the clinic. And then there is a third pass, a third flow, I should say, where the MD reviews the chart. We'll look at all three of these, but we're going to start with the patient calls the clinic. Then we're going to look at how the physician reviews the chart, and then we're going to focus on the center flow or the main flow. So, first of all, a parallelogram, which is the symbol for input, a special symbol that can be used, has been used to distinguish the three variations in how the process starts. And the variations exist because even though the clinic is encouraging their patients to call the pharmacy and not the office for prescription renewal, The clinic's receptionist still gets calls from patients for renewals. We don't know how many, certainly not from this flowchart. The receptionist responds that the patient must call their pharmacy, and that ends the workflow. Obviously, the main flow is how we process the requests from the pharmacy. But as I said, we're going to cover the physician reviewing the chart next. So the third way that is possible, is not very frequent, is that the physician seeing the patient during an office visit will review the patient's chart, though what part of the chart is not identified in this particular diagram, to presumably identify if a renewal might be needed, though this decision is not explicitly shown, and writes the prescription renewal and gives to the patient and documents in the chart. Again, presumably on a medication list that the prescription renewal has been approved, and this ends the process. Notice that while I talked about this part of the flow, I emphasized the word if. Anytime the word if is used, that should alert the process mapper that there is a decision. There's at least two branches or two ways to do something, oftentimes more. So if should be considered an important trigger point. Now let's turn our attention to the major workflow. This is the one handling the calls from the pharmacies or the faxes. It is noted in this map that a pharmacy may call or fax, but it is not clear if the receptionist handles these first or if the RN handles them first. This appears not to be a decision because in either case the RN requests the chart, the process for which is not described here. What is also not identified is how long it takes to get the chart. And I mention this for two reasons. First, delays in addressing medication renewals is a common complaint of both patients and pharmacies. Second, the system's flowchart does not explicitly accommodate documentation of delays or time required to perform a task. There are ways to incorporate this information, generally using a decision symbol to reflect whether there is a delay, perhaps beyond the target time of 1 hour, 1 day, or whatever it is. So this is an important consideration as you use any of the charts. What are the chart's strengths and weaknesses? Let's go back to this flow. The next step is RN reviews the chart, though we do not know what is reviewed in the chart. And we know, just from our own personal experience, there is typically a protocol RNs follow, but this should be clarified as it should be a point considered during process improvement, because in fact there may not be a documented protocol, or there may be sort of a protocol, but it's not always followed. The next step then is that RN determines if it is okay, presumably, to approve the renewal or not. This is a decision point as shown, because if the RN determines, there's my if again, if the RN determines it is appropriate to renew the prescription, the RN then documents on the med list, presumably in the chart, and the RN calls the pharmacy, presumably to okay the renewal of the prescription. The last step is identified, again in a parallelogram, as the call sheet fax is either 1 discarded, 2 kept for 1 week, or 3 filed in the chart. A few things here. 1, this is the first we see mention of a call sheet identified, which presumably comes from the pharmacy call to the receptionist, but we don't know that from the first step there. Second, this last process is actually a decision or 3 alternatives, which should be described using a diamond shape. Are there 3 RNs that do things differently? Or are there 3 ways to handle the completed call sheet or fax by one RN based on some sort of criteria not specified. Finally, following from the above, if the RN does not find that the prescription should be renewed, the RN places something not specified, presumably the chart, in the physician's box. The physician then determines if it is okay, presumably to renew, though we don't know that that is what's actually happening, or the criteria being used by the physician to make this decision. And if yes, documents in the chart. But what and where in the chart, again, we don't know. And whether or not the MD okays the renewal, the MD speaks to the RN, presumably whether or not to allow a renewal, and the flow then returns to the RN to call the pharmacy, again, presumably with the information the prescription should or should not be renewed, and presumably the pharmacy advises the patient to make an appointment with the physician if it's not approved. As can be seen by how the flow chart has been drawn and the commentary we just went through, there are a lot of presumptions in this rendering of the first pass of the flow chart. Even though this would seem to be a rather simple process and workflow, the fact that there are missing elements makes it difficult to review for improvement. The final step that should be taken then is to brainstorm with all stakeholders to the process what might be missing, what needs clarification, and whether the actions, credentials, and flow is accurate with respect to how the process is done today. Although we don't want to start analyzing this for improvement until the current as-is map is complete, we should be thinking ahead a bit with respect to the questions we ask to determine if the map is complete. Now, I've attempted to show as many of the presumptions identified in the last discussion as I could possibly fit on this slide, and there may be a few that are missing. But let's take a look at the key ones that I've identified again here. The first step in looking at this is to identify that there are parallelograms starting each of the flows. These inputs, if you will, could really be operations rectangles or even boundary symbols. Patient calls with respect to the renewal. How frequently is this happening? Would be something that I would want to know with respect to the current workflow. And this is because if it happens a lot, it certainly would be a target for improvement. But if it's not happening frequently, and in fact the number of calls is significantly dropping over time, it may be something that we can let slide, not pay attention to, or keep monitoring for improvement later. We then looked at the right-hand flow where the MD reviews the chart. What information is the MD looking for? And then following that, MD writes renewal and gives it to patient. How does the MD decide to renew, and what happens when the MD doesn't decide to renew? So those are some issues with respect to that. And of course, MD documents and chart, we don't know what exactly is being documented, and so forth. And we presume that the patient has the renewal and not being sent to the pharmacy, which is certainly a possibility, even in the current environment. Let's now look at the center of this flow chart and the main flow. Looking at the RN requests the chart, we should know how frequently this is done, and is it done in a timely manner. The RN reviews the chart. Is this also done in a timely manner? There could be a delay in the nurse requesting the chart, and there could be another delay in the nurse reviewing the chart. We also said before, what information is the nurse looking for when it says review chart? With respect to the decision, on what basis does the RN decide it is okay to renew? And again, where the physician is being asked apparently to look for the renewal, on what basis does the MD decide it is okay to do the renewal or the refill? What is the MD telling the RN at the conclusion of that part of the flow so that the RN can call the pharmacy? And finally, this last parallelogram, where does this call sheet come from? Probably the receptionist takes the call, but we don't know that for a fact. And then finally, this should be a decision symbol that should explain the variation in what's happening here with discard, keep a week, and file and chart. Now, in addition to these that we've already covered, some additional considerations might include information on how long the process takes overall, in addition to where delays may be occurring. Again, in value-based care especially, we want to be very timely in our processing of renewals, and they can literally take several days, if not a week or more, to occur in a current environment. Another question I think that should be asked in terms of accuracy of this as-is current flow is the RN actually an RN or an LPN CMA or none of the above or something else? Many clinics refer to every clinician who is not a physician as a nurse. The credentials could significantly impact, however, how you may be able to revise this process. For example, depending on state licensure requirements, only RNs may be able to approve a prescription renewal, and in some states, not even RNs can do this, so the entire process would have to flow back to the MD. It is also not clear from this flow chart, this as-is flow chart, if the chart is an EHR. While staff would clearly know this, the degree of paper processing accompanying EHRs can still be a huge issue. Also, an EHR could be designed to automatically fill a renewal protocol that could be accessed by whoever has authority to approve a renewal. In fact, it could even be possible for the pharmacy to seek this information via a patient's personal health record linked to the clinic's EHR, though here I admit I'm dreaming a little bit. I do also want to remind us that some organizations have strict protocols the nurse must follow to do a renewal if RNs are allowed to do the renewal. Others have looser policies that may result in patients not being seen for follow-up visit or labs checked in order to ensure proper dosage. And in some cases, nursing staff are not working to their credential, and in others they are working beyond their credential. So that protocol is extremely important. Similarly, the basis for the physician to decide to approve a renewal should be mapped. In addition to the fact that most states have laws that specify the nature of drugs for which different levels of nursing staff may or may not approve referrals, physicians may want to review charts for certain types of patients or certain conditions under which those patients are requesting a renewal. However, it is also found that without a protocol even for the physician to follow, things like the kindly old gentleman may get a renewal where the nasty young woman would not and be required to come into the office even when it really isn't part of the protocol. In summary, this was actually a great start to mapping the prescription renewal process. Believe it or not, it is actually better than many I've seen as I've worked with a lot of clinics. Still, there is much to clarify before the improvement steps can begin with a final map thoroughly documented. The end result, obviously, of mapping the current as-is process should be a comprehensive picture of the process and how the various steps and all decision points flow. Although the map illustrated here may not be easy to see, it is intended to illustrate just how detailed a complete map can get. Certainly, by addressing all the presumptions in the previous discussion, would yield a much more complex chart than what was presented initially. We don't need to read through this that is here on this slide, but it is an example of a final current map that is also about a renewal process, but has a slightly different set of workflows at the beginning of the process. And this is to emphasize that every organization will have differences in their workflows and processes. It is the task of the workflow redesign and process improvement team to help streamline and standardize workflows and processes to the extent possible for efficiencies and effectiveness. However, maps need to be sufficiently detailed that all elements of how a process is performed today can be understood so that appropriate changes can be anticipated and made. Just as it cannot be expected that every organization will perform workflows and processes in the same manner today, it cannot be expected that one size will fit all for an improved state.